So at this time, I'd like to present our first speaker, Dr. Mitra Sorooshian. Her professional experience includes, she's a nephrologist here at the Palo Alto Medical Foundation, Sutter Health, and in Mountain View. She's the medical director at the Satellite Dialysis Unit in Sunnyvale. Her educational training has included nephrology fellowship with Stanford University, internal medicine residency at Lenox Hill Hospital in New York, and medical school at the University of London in England. Please welcome Dr. Mitra Sorooshian.
First, I want to thank you for inviting me to speak here. So Linda asked me to give a presentation trying to explain the lab results, the common labs that we order in patients with kidney disease, and hopefully try to make it a little easier to understand. So with the advances in technology and availability of electronic medical records, all of us can see our lab results. That's good in some ways, but sometimes, unfortunately, it creates a lot of confusion and anxiety, especially if we look in different websites and find different information, and I have a lot of patients who get very anxious about certain lab results. So before I review the lab results, if it's okay, I'm just going to quickly review what I'm sure most of the audience here know everything, but just a quick review of the kidneys, what they do, and what the problems could be. So as you know, most people have two kidneys. The kidneys are located in the flank area. Their main function is filtering blood, getting rid of the excess water, toxins, excess metabolites, and byproduct is urine that comes with these tubes called the ureters. It's stored in the bladder and excreted through this tube called the urethra. So the main kidney function is filtering blood and getting rid of the toxins, but kidneys also secrete hormones that most of us are not aware of. So these include renin that regulates blood pressure control. Then we have erythropoietin that stimulates bone marrow to make blood cells, so people with kidney disease can become anemic, and also activation of vitamin D that is important in bone and calcium and phosphorus metabolism. And I'll go through this in a little bit more detail. So as we all know here, the incidence of kidney disease is increasing in the United States and across the world. So it's estimated up to 15% of US adults have some degree of chronic kidney disease. This is up to 30 million people. And about half of them do not know they have any underlying kidney disease. And kidney disease tends to be more common in men than women, 16% versus 13% on recent statistics. And it's more common in ethnic groups like Blacks, Hispanics, Pacific Islanders, and native populations than in whites. Some of that could be genetic factors. Some of that is related to higher incidence of diabetes, hypertension in some ethnic groups. So this is a slide from USRDS that shows the incidence of end-stage kidney disease. This is people who need dialysis or transplant, and as you notice, the incidence has really gone up almost exponentially over the past 30 years. What you notice here, unfortunately, you see that the number of transplants has not really changed that much, even though the number of patients who need it is increasing. Okay, so there is no routine recommendations about checking kidney function tests in regular population. Most people, when they go to do their routine physicals, their primary care physicians do order a urine and a blood test, But this is the high-risk population, patients with diabetes, high blood pressure, any form of cardiovascular disease, hypertension, heart disease, heart failure, strokes, autoimmune disease like lupus, rheumatoid arthritis, patients who've had recurrent kidney stones or kidney infections, patients with cancer, especially after getting chemotherapy, anybody who has a family history of kidney disease, older age population, and also patients who take non-steroidal anti-inflammatory medications on a regular basis. These are over-the-counter medications like Aleve, Advil, Motrin, ibuprofen, or prescription medications like Celebrex or meloxicam that a lot of us use these days. Okay, so just quickly, in diabetics, we recommend getting a urine and a blood test for kidney functions at least once a year, and patients who get diagnosed with hypertension should have a kidney test and a urine test at diagnosis, and if normal, at every 3 years. So what tests do we use to evaluate kidney function? This is a number of blood tests and urine tests that I will go through today. There's also radiological studies and, in rare cases, kidney biopsy that I'm not going to go through today. That's a later talk. So first we'll talk about blood tests. So these are the tests that I'm going to go through: serum creatinine, glomerular filtration rate, creatinine clearance, BUN, and cysteine C. And I'll try to make it as simple as possible and hopefully not confuse everyone. So the first one is serum creatinine, which is the routine test most of us use to measure kidney function. So creatinine is a normal product of muscle breakdown and muscle metabolism. So all of us, as we walk, we exercise, we do our daily activities, we break a little muscle, and the kidneys get rid of it. So it does go up if the kidneys are not functioning. Now, this is the normal range for average men and women. So for an average man, a normal range of creatinine is 0.8 to 1.3 milligrams per deciliter. In women, is a little less, 0.6 to 1 milligrams per deciliter. Now, one thing that is very important is there is a normal variation or lab error. So even if you get your blood test done in the same lab, there is up to about a 0.1 milligrams per deciliter, which is a normal variation. So if you go 1 month and your creatinine is 1.3 and the next month is 1.4, it doesn't necessarily mean that there is a deterioration in your kidney function. So a lot of us nephrologists try to look at the trend rather than one absolute number. So creatinine is an estimation of kidney function. In some patients, creatinine, or some people, the normal creatinine is a little higher than what would be for the average population. This creatinine is increased with very high protein diets. So as you know, kidney disease patients, we always recommend low protein diet. People who have very large muscle mass, like athletes, bodybuilders, they do have a normal higher creatinine. So it's not necessarily abnormal. Anabolic steroid use also increases creatinine, and that's not recommended for health anyway. People who have muscle injury can increase their serum creatinine, and there are certain medications that can increase serum creatinine without affecting kidney function. This includes cimetidine or Tagamet that is available over the counter for acid reflux, and trimethoprim, which is part of an antibiotic called Bactrim that is used very frequently. And there's a list of other medications. So that's creatinine. So just to summarize, it's the test that we use to measure kidney function, but there is a slight lab variation. So it's the trend that we look at, and there are certain populations that the creatinine may be higher than the normal range. So the next test that you see on your lab results is something called glomerular filtration rate, or GFR. So this measures the level of kidney function, and also we use the GFR to stage what stage of kidney disease patients are in. Now, a normal GFR depends on age, gender, and body size. So I'm just going to go to the next slide and just give an average normal eGFR based on age. Now, a GFR is sort of like, and we use it as like an estimate of kidney function. So the number of eGFR could be like a percentage of kidney function. So between the age 20 to 29, the average eGFR is about 116. 30 to 39, it drops to 107, 40 to 49 to 99, and it goes down, so age 70 plus, an average eGFR is 75. Now, the reason for that is there is some natural aging in the kidneys, like all the other organs in the body. So with age and some other factors, possibly medications, there is some degree of scarring that happens in the kidney. And actually, there are some studies that have been done on patients, so-called normal patient population over the age of 70, and at least 50% of the US population over the age of 70 do have an eGFR less than 60. So again, these numbers that may be very scary may not actually be as bad as you think when you look at your lab results. So most of us use estimated GFR. So the estimated GFR really uses the creatinine, age, gender, and racial group, and puts it in a formula that gives us an estimate of GFR, or percent kidney function. And for most people, it's very accurate. So now, these are the stages of kidney disease that we all know, from stage 1 to stage 5. And it really depends on the GFR, or percent kidney function. So stage 1 is pretty normal kidney function, except there are some other abnormalities like protein excretion in the kidney. Stage 2 is mild kidney disease, GFR between 60 to 89. Stage 3, moderate, 30 to 59. Stage 4, between 15 to 29 GFR. Stage 5, less than 15. Now, stage 6 or stage 5D is when patients need dialysis. And really starting dialysis is really very much dependent not just on GFR, but also on other factors, like how the patient feels, what the potassium levels are, what the fluid status is. So there are some people who need to start dialysis earlier, and there are some patients who can go without dialysis until GFR drops below 8. Majority is 10. That's the magic number for most people, but again, it's very individual. Okay, so that's eGFR, which is estimation of kidney function based on creatinine. Now, if you want to do a more accurate measurement of the GFR, we do something called a creatinine clearance. This is a test when we measure the blood creatinine, and it involves doing a urine collection for 24 hours and measuring the creatinine in the urine and the blood, and really measuring a more accurate percent kidney function on that. Now, this test is really done mainly on certain patients. Like I talked about, if somebody has higher body mass, body muscle, body builder, that we suspect their GFR is not accurate, we order the test. A lot of times they do it on potential kidney transplant donors before they take a kidney, just to make sure they have good kidney function. In majority of patients, the creatinine clearance correlates very closely to the eGFR. So majority of nephrologists don't really order it, but you may be asked to do it for those situations. It is bothersome. You need to collect your urine for a whole 24 hours, refrigerate it, get it to the lab in a timely manner. So it's not done that frequently. Now, other tests that you may see on your lab results include BUN, or blood urea nitrogen. This is another product of metabolism that is excreted by the kidney. Normal range is between 6 to 25. It's not as accurate as creatinine for measuring kidney function because it's easily affected by factors like dehydration, high protein diet, bleeding. But if you see on a blood test that your BUN is high, it usually means you're dehydrated. So drink more water for sure. And then it can be really low in patients who are malnourished, have low protein diet, or have liver disease. So it's not a very accurate way of measuring kidney function. And again, this test, cysteine C, some of you may have seen that, is another way to look at kidney function. It's not done very frequently. It's another product of metabolism that is secreted at a very constant rate and is not affected by diet. So some physicians, when they're not sure about the creatinine level, they order cysteine C. If both cysteine C and creatinine are elevated, then it's more likely to have kidney disease. But majority of us don't really use that test. Okay, so creatinine, eGFR, both are estimation tests that we use to estimate kidney function. So for majority of people, those give an accurate assessment of kidney function. So far, everybody's clear? Okay. Now we'll go to the minerals that are very important to check in patients with kidney disease. These include potassium, and I think most of you at one time or another have been told about potassium and the importance of restricting potassium. So potassium is a mineral that comes from food, and it's very important for daily bodily functions. So normal range is between 3.5 to 5 milliequivalents per liter. Now, high potassium levels or hyperkalemia are very common in patients with kidney disease. The reason is that the kidneys excrete potassium and excess potassium. So if you have kidney dysfunction, the kidneys usually don't excrete the excess potassium. And also, we use medications like angiotensin-converting enzyme inhibitors, angiotensin receptor blockades. These are medicines like lisinopril or losartan that protect the kidneys. So these medicines also independently retain potassium that contributes to hyperkalemia. And as kidney disease patients, you should all know you should not be taking non-steroidal anti-inflammatory medicines, but those also cause potassium retentions. Diet, and I'll put a slide about dietary factors, but salt substitute. A lot of patients who are hypertensive, because they're salt restricted, they take salt substitute, which is a potassium salt. And it's not a good idea to take. And herbal supplements, we try to recommend patients don't take, can also have potassium, high potassium levels. Another thing is like heart-healthy cereals. Certain cereals have potassium added to them. So if you buy those, you need to check and make sure there's not additional potassium. Now, why is hyperkalemia important? Most people, if they have potassium levels of less than 5.6, they don't have symptoms and it's mild hyperkalemia. But especially if the potassium levels go above 6, they can be very dangerous. It can cause muscle weakness, sometimes it can cause paralysis. The main problems are cardiac arrhythmias. Patients can present with very serious cardiac arrhythmias and even sudden death. So that's why it's so important to control potassium levels. Now, I got this slide right out of the National Kidney Foundation. So this gives an idea of what foods are high in potassium, which is the fruits, vegetables, and other food, and some alternatives. I think most of us know bananas, avocados, a lot of fruit and vegetable juices. They're high in potassium. Potatoes are also high in potassium. One trick with potatoes is peel them and soak them overnight. That takes out the potassium, so you can eat some. I won't go through that in too much detail. It's pretty self-explanatory. Okay, so that's potassium. So we need to keep the potassium in good check because high potassium levels can have serious life-threatening consequences. The next test is something called serum bicarbonate. Now, this measures the acidity in the blood and is low in patients with kidney disease because a lot of people have inability to excrete extra acid. And a normal bicarbonate range is between 24 to 31 milliequivalents per liter. And the reason we are concerned about low bicarbonate levels and acidity in the blood is that long-term it can cause bone loss and also muscle weakness. And very low bicarbonate levels can also cause shortness of breath and exercise intolerance. So we usually try to keep it above 21 milliequivalents per liter by using bicarbonate salts. Okay, so bone disease in patients with kidney disease. Now, this is a little bit confusing, so I try to explain it a little bit more, and I'm sorry if I make it a little too complicated. So you all know we always talk about phosphorus, the importance of controlling phosphorus levels and parathyroid or PTH levels. So to grow healthy bones and turn over bone, we need a number of things, including calcium, phosphorus, an active form of vitamin D, and something called parathyroid hormone. So the kidney is involved in bone metabolism because, as I mentioned before, kidneys remove extra phosphorus. So if you have kidney disease, the phosphorus is not excreted and can accumulate in the blood. So, and also, like I mentioned before, kidneys activate vitamin D, so patients with kidney disease can develop a form of vitamin D deficiency. Okay, so this tries to explain what happens, and I'm sorry if it's confusing. So when people have kidney disease, the kidneys do not excrete phosphorus. So the phosphorus levels go up in the blood. Kidneys don't activate vitamin D, so the levels of vitamin D are down. And that causes low calcium levels because calcium is not absorbed properly. So the combination of low calcium, high phosphorus causes these little glands in the neck called the parathyroid glands that are located just behind the thyroid, nothing to do with the thyroid, to hypertrophy and excrete too much parathyroid hormone that in turn goes to the bones and causes bone loss, which can get very severe over time. So Linda asked me to put the normal levels for calcium, phosphorus, and PTH. So the normal calcium levels are between 8.6 to 10.2, target phosphorus between 2.7 to 4.6, And the parathyroid level depends really on the stage of kidney disease. So in stage 3, normal is between 30 to 70. Stage 5 is 150 to 300. And in dialysis patients, the normal levels are actually a lot higher, 2 to 9 times normal. So having said that, now we talk about why it's important to keep the phosphorus levels down. Now, phosphorus comes from food, and really the only way it gets excreted is through the kidneys. So when people have kidney disease, they need to cut back phosphorus intake, and the recommended amount is 0.8 to 1 grams per day. And I'm sure we all, there's like list of high phosphorus containing foods, but the main ones are dairy products: milk, ice cream, cheese, all the good stuff. Nuts, any form of nuts, peanut butter, they're also high in phosphorus. Beans, chocolate, sodas that nobody should be really drinking also are very high in phosphorus. Processed meats like hot dogs and any processed food that has phosphorus additives should be avoided. Now, in later stages of kidney disease, when the dietary restriction doesn't work by itself, they prescribe medications called phosphate binders, usually closer to dialysis. Now, why do we want to control phosphorus PTH levels? As I mentioned, if we don't control it, there is a condition called renal osteodystrophy that causes bone loss, bone pains, and bone fractures. And I just brought some pictures just to show you. So if you notice, these are like areas of bone riots in severe secondary hyperparathyroidism, and these are very painful, and also they can cause spontaneous fractures even without any severe trauma. So we really would like to avoid that. And other things that can happen with poor control of phosphorus is what we call vascular calcification. So this is a blood vessel that supplies the foot, and you can see this is not normal. You should not be able to see the calcium deposition in the blood vessels, but you do. And unfortunately, this can cause lack of blood flow, gangrene, and amputations in patients. And it can happen in the heart, in the brain. So another reason phosphorus and calcium levels need to be controlled. And this one is a rare, very severe fatal consequence, something called calciphylaxis, which is we mainly see in end-stage renal disease patients who are on dialysis with poor calcium phosphorus control. What we think happens is that because there is vascular calcification in the small blood vessels, there's not enough blood flow to the skin, and initially patients present with very painful nodules, but it can progress to really painful necrotic lesions like this, and a lot of times is fatal. So, calcium phosphorus metabolism, another very important thing. So something very important to look at on your blood tests, and the parathyroid hormone as well, and discuss with your nephrologist. Okay, I hope everybody is not confused. The last blood test is anemia. So hemoglobin or hematocrit, these are tests that measure, look for anemia. And hemoglobin measures part of the red blood cells that carry oxygen. So if we are anemic, we have poor exercise tolerance, fatigue, and these are, of course, important for quality of life. So anemia is very common in patients with chronic kidney disease because, as I mentioned before, kidneys produce this hormone called erythropoietin that stimulates the bone marrow to make blood cells. So we see anemia very commonly. Again, it's defined as a hemoglobin of less than 13.5 grams per deciliter in men and less than 12 grams per deciliter in women. Treatment for anemia with erythropoietin is usually indicated for most patients when hemoglobin drops below 10. And the target for keeping the hemoglobin is between 10 and 11. Okay. All right, so I'm going to go to urine tests next because everybody who sees a doctor, especially a nephrologist, should have a urine test done because it's very important. And there are different urine tests that are done. There's the urine analysis, urine for microalbumin, urine to protein to creatinine ratio, and less commonly, 24-hour urine protein. So when you do a urine, first we look at it, look at the color, turbidity, and then we do a dipstick test, which is really a stick that you put in the urine, take out, and then look for color changes that would indicate different things. So the main things that we see is whether there is any glucose in the urine that is obviously abnormal. It can indicate diabetes. And then blood. Nobody should have blood in the urine. Having blood in the urine is abnormal. Protein in the urine is abnormal. And white cells and casts should not be present. So I'm going to talk about certain urine abnormalities that are abnormal and need to be investigated. So the first one is hematuria. This means blood in the urine. So sometimes you can see blood in the urine, but majority of time it's just picked up on a dipstick. So it's defined as more than 2 red blood cells when we look at it under the microscope. So blood in the urine can come from any part of the urinary tract. It can come from the kidney, from the ureter, from the bladder, and in men from the prostate. So it could just be infections that that cause the blood in the urine or hematuria. It could be kidney stones, sometimes trauma to the kidney, or very vigorous exercise can cause blood in the urine. More serious conditions include kidney or bladder cancer, and sometimes glomerulonephritis or inflammatory conditions in the kidney can cause blood in the urine. At times, there is no cause found for blood in the urine, and sometimes there are benign conditions, but anybody who has blood in the urine should have further workup. The next abnormality is proteinuria. So again, normal kidneys don't leak protein. If there is protein in the urine, there is a kidney problem. So most patients, again, don't have symptoms, but rarely patients notice they have foamy urine or bubbles in their urine. Usually that's when there is significant amount of protein. And again, you pick the protein in the urine on just a simple dipstick test. It tells us whether there is protein, and depending on whether it's trace, 1+, 2+, 3+, or 4+, which is a color change, it tells us what the severity is. So protein in the urine is abnormal, and if you have protein in the urine, any degree, it needs to be further worked up. Now, the next one is microalbuminuria. Diabetics are probably familiar with this test. This is a test that looks for minute amounts of protein in the urine. So this is even before the dipstick test shows any protein. And it's defined as albumin excretion at 30 to 300 milligrams per day. And the importance of checking for microalbuminuria, particularly in diabetics, is that when patients get microalbumin, that's the earliest stages of diabetic kidney disease. And that's the time to get proactive with controlling diabetes, high blood pressure, because it's still reversible. So if you have microalbuminuria and you get on top of your disease, you can reverse the progression of kidney disease. In patients with cardiovascular disease, if there is microalbuminuria, it usually indicates there is higher morbidity and mortality. Now, if there is microalbuminuria, it doesn't mean that everything is lost. Then we can make it disappear by controlling our diet, low sodium, low animal protein, tight control of blood pressure, blood glucose, and using medications, angiotensin-converting enzyme inhibitors or angiotensin receptor blockades that protect the kidney. Okay, so the last test, which is also confusing, is something called urine protein to creatinine ratio. So this test we do in patients who have proteinuria to quantify the degree of protein. And the reason for that is we want to assess treatment and see how effective treatment has been. So it is a ratio, it's not an exact test. So a lot of my patients get confused when they see urine protein and urine creatinine numbers by themselves. By themselves, they don't mean anything. It's really just the ratio we're looking at. So a normal ratio is less than 0.15. Of course, low grade 0.5 to 1, and nephrotic range proteinuria is more than 3.5. The higher the protein excretion, the worse the prognosis is. So we like to get the protein excretion to the lowest number possible. And this is an alternative to doing a 24-hour urine collection that some of you may have done, which can also measure urine protein. So urine analysis also very important test. If there is any blood or protein in the urine, it's not normal and it needs to be evaluated further. Okay.
Thank you, Dr. Sorooshian. Does anyone happen to have any questions at this time?
I have a question regarding your statistics about 48% of the population does not know that they have kidney disease. What was that number? I thought it was 90.
This is 48% of the people who have CKD don't know they have CKD. And I think part of the problem is, I mean, a lot of us do our routine physical exams, but some of us don't. And especially kidney disease is a silent disease. A lot of people don't have any symptoms. So unless we get a blood and a urine test regularly, we may not know we have CKD. And unfortunately, the more and more of us are taking the NSAIDs, pain medications, and now you see, kids are doing sports more and more, and they do competitive sports. And I see even 10, 11-year-olds who pop Advils and Aleve because of joint injury. And whether that is a contributing factor, who knows? I mean, I'm sure it does. And of course, the higher incidence of diabetes, obesity, heart disease, hypertension, our diets that are getting worse and worse with more processed food, that all probably contributes.
And I have one more question about the PTH. You said the normal range was between 150 to 300.
That's for stage 5. For dialysis, yes. For dialysis patients is a little different.
You said it was like 2 to 9 times?
Times normal, yes.
So they could go up to like almost 3,000?
Well, I mean, this is the recommendation and depends on the dialysis unit. So I think majority of dialysis units want to keep the PTH between 150 to 800. That's the number. Upper limit of normal is 70. So, and the reason for that is if you overtreat secondary hyperparathyroidism, you can get something called low bone turnover. So actually the bones don't turn over at all, and that causes another cause called bone problem. So every stage of kidney disease has slightly different recommendations. And they change every few years,
I want to thank you for that presentation. We go back for many years, and I just want to thank you that when you started, I followed you all the way through to
Are
every
you
week.
Shirley?
Yes.
Is that you? I didn't recognize you. Yes, Shirley. Yes, I go back with Shirley to Valley Medical Center, like almost 30 years ago when I was a fellow.
38 years ago.
Oh my God, yes, yes. Shirley is amazing lady. And I'm sorry you're on dialysis.
Thank you.
I just have a quick question, and I was hoping, because Shirley's my friend and neighbor, and I'm assisting her in this transition, but my question is, and I didn't know if you were going to talk about it, I wanted to talk a little bit about the dialysis bath and the changes that go on. And I don't know if you can explain it a little bit, but I want to know if that has an effect on the patient as far as after they get off of it and what actually, I know the bath cleans the blood, but there's just distinct signs I see after her treatment sometimes.
So the dialysis bath is, so what dialysis does is a diffusion principle. So you have a bath that has low concentrations of a lot of the stuff we want to remove so that like the extra blood urea nitrogen or the potassium is removed. So the bath has certain amount of sodium, potassium, bicarbonate, calcium, magnesium, and sugar in it. Now, the potassium level is changed every month depending on the blood potassium level. The sodium level is really what determines how people feel. In the old days, like 10 years ago, we used to use something called sodium modeling. So we used to really increase the sodium in the bath so we were able to remove a lot of fluid without patients feeling symptomatic. But then we noticed patients got really thirsty and drank more fluid in between dialysis. So now we try to keep the sodium level at a normal range. Now I think it's not that much the bath as much as it's the amount of fluid that's removed during dialysis. So most patients, if they limit fluid removal to 1.5 to 2 kilograms, they're not as symptomatic. If it goes above 2 kilograms, because there's so much fluid removed in a short period of time, that can cause problems.
Is that a standard, the 1.5 to 2 kilograms?
Well, I mean, we
Or is
try
that
to
based on the
limit the
patient?
fluid removal, but sometimes, unfortunately, most people do 3 times a week dialysis. The home dialysis that this gentleman did is a much better option. But say if you leave on a Friday and you come back on a Monday with 4 or 5 kilos fluid, if that's not removed, then there's a risk of going into fluid overload and heart failure. And so the staff try to remove that as much as that fluid as possible on that day. And the reasons are different. Sometimes patients don't want to come for an extra run. Sometimes there is no availability to do an extra run. So it's a combination because, we try to tell everybody, limit your fluid intake. And during the week, when there is only 1 day in between dialysis, is easier. On the weekend, when there is 2 days, it's harder. But if people limit their fluid intake, it really helps the symptoms on dialysis.
Thank you.
I think there were some other questions here.
Excuse me, doctor.
Yes.
How bad your kidneys have to be before you go on dialysis?
Well, that has to be less than 10% kidney function for majority of people. Some people can go on until they're less than 8, but majority is less than 10%.
What stage is that?
That's stage 5, which is less than 15.
I can speak loud. What would you recommend for somebody with low hemoglobin, like between 7 and 11, dietary or supplements?
Well, I mean, when patients have low hemoglobins, we always check the iron, the vitamins. Between 10 to 11, we don't recommend erythropoietin. We used to do it many years ago, but then there are different reasons that is not recommended. One is reimbursement from Medicare and insurance company. And the second really is because erythropoietin is not without its adverse effects. It can contribute to blood clots. It can have other adverse effects. So sometimes we recommend iron supplementation. Of course, like everything else, the more active people are, the less symptomatic they are. But with herbal supplements, you have to be really careful. So maybe iron in some patients.
Are there any more questions for the doctor? This time, thank you so much.
Thank you.
I have just one more.
Yes.
Real quick. When it comes to food intake, I cross-reference a lot of stuff with the National Kidney Foundation because there seems to be a lot of contradiction on what the patient can or
cannot have, and one of it is around phosphorus, and then especially around soda or cranberry, stuff like that. But there's some soda they say if it's light, like 7-Up or Slicers, right, it's acceptable. It's the dark colas that they can't have, and I wonder if it's really just driven by individual patients' numbers.
I think there is a little potassium in almost everything, So it's the amount of potassium. So like a banana is full of potassium, whereas like a blueberry or a strawberry, the concentration is much less, or apple and pear. So it's like eating that has a lot less potassium than the high potassium containing food. And it does get very confusing because, being a diabetic, sometimes there are things that are low in potassium that are high in carbohydrates, and it's like a balancing act. So you have to, of course you have to eat something, but I tell most of us, if we try to eat fresh food and cook at home and not eat out and not eat processed and fast food, already we are doing good. So that's the best recommendation for most people. And again, it's a balancing act. Don't eat the very high potassium containing food and a little bit of everything else.
Excellent. Thank you, doctor.
Thank you.